The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to santanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding. Thank you for choosing to spend a little time with me here today. And of course, today is the day after the Iowa State-Iowa game, and I'm recording before the game, so I don't know how it turned out. I don't have a dog in the fight. I used to cheer for Iowa State more because one is in the Big 12, and I'm an Oklahoma State grad, and the other is that it kind of has that same sort of little brother school as Oklahoma State does to Oklahoma. But now my oldest daughter is considering going to Iowa, and I just enjoyed watching Caitlin Clark play so much, and it seems like the Hawkeyes have learned to score a touchdown, which might make their games exciting again. But yeah, full into it. Like I said, I don't really have a dog in the fight. I hope it was a great game. And here we are. It's fall. It's football. I just love this time of year. There's something about the angle of the sun that is just so special this time of year. It's different than the spring, even though ostensibly it would be just the opposite of it. But yeah, I don't know. There's something about the fall sun and the weather and the crispness in the air, and hunting season's coming up, and all the good stuff. All the fall foods, which I'll not be eating. I'll be eating fall ground beef and fall steak and fall pork chops, but still not doing the vegetables yet. And we'll see what happens at my 1-year check-in. And I think that I'm going to have to figure out, I don't know, I have to figure out something rather than just eat meat for the rest of my life only, but gosh, it's working so well for me that I'm in no hurry to change. I still got about 20 pounds I'd like to lose, even though if I look at myself, I'm not super displeased. I just want to see how slim and how healthy I can get. I guess that's the point, right? And so one thing about this time of year is to me, it's harder to stay in shape in the winter. So right now you should be out walking, and whatever you do for exercise, whether it's walk, go to the gym. If you're a gym goer, it's not that big of a difference, but I have a feeling many people here listening to my show are not gym goers. And of course you have, obviously the farmers are going to be real busy right now and getting plenty of exercise at work. But if you walk for exercise, maybe walk a little extra over the next 2 or 3 months until you can't. and just remember, diet is 80% of weight loss. However you want to get there. I saw a great poster outside the fair said you can't outrun your corn dog, and that's the case. You cannot outrun your corn dog. So, or your apple pie, or your ice cream, or any of that stuff. So it starts with diet, as hard as that is. And to those farmers that are working a lot right now, just make sure, it doesn't hurt to do a little bit of stretching in the morning and stretch your body out so that you don't get injuries. I had a farmer a few years back. He had a Fitbit or something that measured his steps. And he said sitting in the combine, because of the vibration, it measured him 10,000 steps. So obviously you're not getting 10,000 steps worth of calorie burning. However, you're getting some because it takes core muscles to stay sitting up, right? But also that's a lot of jostling. So a little bit of stretching in the morning. I mean, even if you stretch for 3 or 4 minutes in the morning, I think it's worth it. I do. Muscles and tendons and ligaments and bone all have different. There's a principle called viscoelasticity, and it's a way of describing how certain things move. And what it is if you pull a tendon or ligament, if you're putting traction on it by flexing the muscle that is attached to the tendon, or by just stretching the joint that is attached to the ligament, because tendons attach muscle to bone and ligaments attach bone to bone. If you stretch them, there is a little bit of that stretch that temporarily is going to stay. So, for instance, if you stretch a rubber band, it's going to go right back to where it was before you stretched it, except for if you really stretch it, and then it's going to take a little bit of time to get back there. That's the viscoelasticity property. And that is taking advantage of the ability to stretch out will help you avoid injury. And also, I know in the operating room, I tend to slump. I tend to bend my neck down because I'm looking down, right? And if you are in the combine, or even when you're driving, if you're driving a lot, whether it's professionally or not, try to touch your shoulder blades together in your back and just get your back stretched, pull your neck back, do that, roll your shoulders, and do that several times a day so that you don't get just stuck in that, even if you're working in a computer, or if you're quilting, if you're knitting, anything that you're doing, just try to make sure that you roll your shoulders back and try to touch your shoulder blades together just by using the muscles, and then roll the shoulders around and roll the neck back and pull the neck. I'm doing it, and that's why my voice went away for a second there. Because it's very important in a lot of ways. If you're hunching over, if you're consistently hunching over, that can cause inflammation just by being in that stressed position all the time. You don't even really know you're doing it, but when you let go and you start that stretch, you say, oh man, that feels a lot better. Just like anything else. If you've been sitting for a long time and you stand up, legs feel good. So these are things that you should be paying attention to, those of you who are, well, really everybody. It just right now is obviously big working time for the farmers. And then also any of you who are out there doing any kind of manual labor, take 3 minutes in the morning and stretch. Just take 3 minutes, and it will reduce your chance of getting an injury. And then also if you can take 30 seconds a couple times a day and stretch. It's just really important. It's something that I think people forget about. I know I forget about it, but I'm pretty good at remembering it. As soon as I feel myself scrunched, I'm stretching my neck back, I'm stretching my shoulders back. And because of that principle of viscoelasticity, it is making it less likely that you're going to get injured, but also it's making it just more balanced, if that makes sense. Also, if you are at all doing any gym work, make sure you exercise your back side as well as your front side. So if you're doing biceps and triceps and chest, you need to make sure and do your back a little bit too. And I've said this a lot, and from every perspective, from the perspective of healthy bones and joints to the perspective of healthy heart and healthy metabolism, lifting weights is probably the most neglected exercise. And whether you've ever lifted weights or not, you can benefit from lifting weights, and you don't have to lift heavy weights. You can get a little weight set that goes from 1 to 5 pounds, and you just do a little bit of exercise with that. Just get your shoulders a little bit, maybe lay down and do your chest a little bit. And if that's hard for you, just do it in a chair. That's the thing. I mean, even if you're wheelchair bound, you still are tremendously going to benefit from lifting some weights in every aspect. So I highly suggest people do that. And if you are getting ready for any kind of surgery, it's even more important. I would just reiterate my support for weightlifting. So I had a patient a couple weeks ago who had his knee replaced and came in and was really kind of taking a lot more pain medication than typical. And I said, I don't know what's going on here. And that's why we do the Iovera and all that other stuff. And he said, oh, I didn't have the Iovera, which I had forgotten. I mean, I knew at one point that, I just had forgotten that he chose not to do it. And he has had the most pain of any patient I've had in a while. Now, that doesn't 100% mean anything, but I can tell that story about lots of patients, I can tell the story about someone having had a knee done somewhere else by someone else who doesn't use an iovera, and then coming to me and having the iovera and saying, wow, this was a lot easier. So for my pain protocol, the iovera is the first step. And I've gone over this a lot of times. I'll just go over it briefly. You get the iovera, which is freezing the nerves with liquid nitrogen. It's IOVERA if you're sitting and want to write it down and take a look at it online. So you freeze the nerves on the front of the knee with liquid nitrogen. Those nerves are injured in a manner that, so the nerve has a body, and then it has an axon, which is the sort of, if you've ever seen a nerve cell, you have sort of like a cell, and then you have a long, basically a tube that goes to the next cell and attaches to that. So this injures that tube in a way. The way I explain it is, if you cut a wire, a copper wire, and you pulled the copper out and you left the insulation, and then the copper would grow back. That's physically what the iovera is doing to your nerves. It's only sensation nerves. It's not nerves that move any muscles, and it's only on the front of the knee. So do that on the front of the knee. Then the day of operation, you get what's called an adductor canal block, which the anesthesia team will do, and that's more blocking. Then you get a spinal anesthetic, and that's more nerve blocking. And then I'll do a little block. It's called a posterior capsular block. So I put a long-acting lidocaine in the back of the knee in the capsule, which is what keeps the fluid in the knee. It's sort of the lining around the knee. And all of those things, so that is outside of any of the actual pain medications. These are all nerve blocks, right? So then you're going to take Celebrex before the operation. During the operation, the anesthetist is going to give you some pain medications, including IV Tylenol. After the operation in the hospital, typically you would get Tylenol and oxycodone and gabapentin, which is a nerve blocker. Oxycodone is the opioid. And then if you're doing well with all that, that's what we send you home with, and that's what you do. I also have a pain cream that I recommend, which is an anti-inflammatory combined with lidocaine, which is, again, a topical pain medication. So you get all of these, and now I'm giving usually 20 oxycodones. And I used to give 60 hydrocodones and 60 tramadols, so 120 pills that had opioids in them now, or opioid-esque. So the tramadol is opioid-esque, and the hydrocodone is the opioid. And so now we give the oxycodone and Tylenol, because I want you to take the Tylenol around the clock, meaning every 6 hours, as it's directed, and then you can use the oxycodone if you need it. And very, very few of my patients ask for refills. About 1% of my patients ask for refills on the oxycodone. And I typically, like I said, I'm giving out 20. I was giving out 10, and the refill requests went up a little bit. So I said, well, we'll give out 20. It's fine. I mean, the ultimate goal would be to do the whole procedure without any opioids at all. But I don't know that I don't know if we'll get there or not, but it's just day and night away from what it was back even 5-6 years ago. It's been 8 years. So when I started using the iovera, it was 8 years ago. It was right when I got here to Iowa. And that's when I stopped giving IV morphine with a push button, so the patient could push the button in the hospital and just get as much morphine as they wanted. Not as much as it was limited. There was a limiter on it. Every 5 minutes you could get 1 milligram or 2 milligrams, depending on the size of the patient. And you would see that patients would have had sometimes hundreds and hundreds of milligrams of opioids before they left the hospital. Then I started using the iovera, and we just stopped that and started going to the pills. Now we've been cutting the pills and adding different pills, and it's really made a huge difference. I mean, most in Des Moines and most big cities, a large percentage of knees and especially hips are done outpatient, meaning they go home the same day. What I find in the population that I have, it's a little bit older, and 90% of our patients go home the next day. And I think staying in the hospital overnight if you're 65 or over, which is 90% of my patients, staying in the hospital overnight is not a terrible idea when you've had a major surgery. Because, first of all, a whole lot of patients have several medical issues. Sometimes things come up. We usually have the pain under control early, but when I look at, so sometimes the pain will get out of control. I mean, what do you do if you're home? That's one thing. But it just works. We admit the patient to what's called observation, and they leave before 24 hours, and it technically is the same thing as going outpatient from the Medicare perspective. And then, of course, like I said, about 10% of my patients, which is a lot if you think about it, about 10% of my patients will stay that second night. Now imagine that 10% of patients was home and had either a pain situation or their blood pressure got a little bit out. I mean, nobody's monitoring your blood. Well, I guess they probably do have people monitor their blood pressures at home, but still nice to be under the care of a good nursing staff for 24 hours after you have a major joint replacement. I just think it's good medicine. I know that there's a lot of studies showing that it's very safe to do in a well-selected patient. But if I had at 54, I guess, with my blood pressure being under control as it is right now and being so much more fit, I probably would think about going home if I was having my knee replaced. But I would also not think it was the end of the world to just spend the night in the hospital. So that's kind of what I do. But what I try to do is I try to get the pain control program to the point where if the patient wanted to go home, they can go home, and that they really are doing really well after the surgery. And there's no guarantees, and there's no, like I said, every once in a while you have a patient that has a whole lot of pain. Typically, like I said, only 10% of my patients require a refill of the 20 oxycodones that I give them. And every once in a while you have someone who uses a lot of them, but it's just not that often anymore. And I continue to look at the studies coming out on the pain protocols and see what else we could do. And, I give some steroids on day one in the hospital, a little oral dose of steroids to kind of help with the pain. It's a powerful anti-inflammatory, the steroids. And then there's a lot of different variables. We use different blood thinners in patients who have different risk tolerance for blood clots. So that's one of the things in a knee replacement, you can have a blood clot. So we're going to give you something. If you're a normal risk, you're going to get aspirin. If you're an elevated risk, you typically get a medication called Eliquis. One of the issues with Eliquis is sometimes it causes too much bleeding in the knee, and then you have what's called a hematoma, a big collection of blood in the knee. And if that's big enough, you have to open it up and wash it out. So it's not a medicine that I like to use, but if a patient is at a higher, or if the patient comes in already on a blood thinner, we put them right back on that, of course. But if a patient comes in and they're normal risk and they're not on a blood thinner, we use aspirin nowadays for keeping the blood thin so it doesn't clot up in the veins and cause trouble, can go to the lungs and cause big trouble. So that's just wanted to give a little bit of encouragement to people who are getting exercise. Go get more while you can. If you're not exercising during the winter, try to figure out a way to. I know some of you are very rural and don't have like a recreation center or a YMCA near, and exercise bikes are great for that. You can get a used exercise bike for not that much. And the more you move, the healthier you're going to be. That's no question. And you combine that with a healthier diet and things look good. And then also just don't forget, do a little bit of stretching. It doesn't hurt. Everybody can benefit from stretching every day. You do 2 or 3 minutes of stretching in the morning and 30 seconds a couple times a day. It really can help you out. So with that, enjoy the fall, and congratulations to the Iowa or Iowa State fans, whoever won the game. And looking forward to a fun fall and a good football season. And you have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. For more information about Dr. Godding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.